once a pharmacological treatment is administered and symptoms improve, that treatment should be normally kept. I mean, it's also true that RLS has frequently a fluctuating course. The physician can try every now and then to discontinue the medication, but in most cases, symptoms will reappear. If they reappear, then there is an indication for a prolonged treatment. However, if we want to be able to reduce the dose of any given medication, what we need is to make sure that we have treated the cause of RLS. And the only disease-modifying strategy that we have so far, and I use the concept of disease-modifying with some caution because data are still very preliminary, is to increase brain iron levels. How can we measure whether brain iron is low or is high? Well, there is a very simple technique which is based on transcranial ultrasound. And it can be learned easily. It's innocuous. It's relatively inexpensive. And by doing that, you can look at the echogenicity of the main iron stores in the brain, which are located in the substantia nigra. And by measuring the echogenicity of the substantia nigra, you can tell whether brain iron is low, high, or needs to be improved any further. Of course, we realize that this technique is not in the hands of every physician. It's not terribly sophisticated, but on the other hand, it's not at the reach. It's not at reach of a GP or so. We realize that. Our recommendation is that unless there is any contraindication for intravenous iron, it should be considered a first-line treatment. And the contraindications would be if a serum ferritin level over 300 nanograms per milliliter. The second contraindication would be a transferrin saturation over 45%. Any family or personal risk of hemochromatosis or any previous history of anaphylaxis as a result of iron. So by treating the causal element in causing RLS, we might be able to influence the future course of the disorder.